now.
Okay. So we will get started. You can tell Josh, and he can come and stay too.
He has another meeting.
Got it. Okay. So let's get started, everybody. You guys will notice that you have paper at each of your tables and markers. Today, we are going to do a clinical reasoning conference. So some of the students that were here last month, you guys might remember this type of conference. Basically, I will give you information 5 times during the course of conference, and you will have a chance to come up with a differential diagnosis for why you think this person is here in the hospital. My hope is that you guys will refine your diagnosis each time I give you new information, and then we'll talk through why you guys think that diagnosis is up for grabs for this particular patient based on the information that we have. So you should write down any information you want to keep in your mind, because once I show you something, it will not come back up again on the screen. And then after each session, we'll come together and talk through each of the groups and say what you guys think is your most likely diagnosis, and then just talk through it all. Questions on that? Okay, and folks on Zoom, you guys can also participate. Please put your answers into the chat, and then we can talk through your clinical reasoning as well. But let's get started. Just a reminder, we have our second Wednesday event, 6:30 at Improper City, if you would like to join us. So here is our first piece of information, and I will read this out to you. We have a 70-year-old male. He's admitted coming in with 3 to 4 months of whole body weakness. He's not able to further localize or describe. He denies any specific onset or onset event. In the same time frame, he's noticed he's had decreased appetite, 4 PO intake. He's lost about 30 to 40 pounds. He came to the hospital today because he couldn't take it anymore and he wants to feel better. He says that he lives alone in an apartment. A neighbor comes and brings him food. And then the person who wrote the H&P comments, he is minimally participatory in the interview, providing one-word answers requiring significant prompting. In terms of his past medical history, he has a history of asthma, chronic back pain for which he's on opiates. He has a history of hyperlipidemia, duodenal ulcers, history of a RPGN that's dealt with now, his normal kidney function, and then sarcoid for which he follows with pulmonary. For his review systems, you guys can see the positive answers there, but appetite change, fatigue, weight change, rhinorrhea, trouble swallowing, shortness of breath, some abdominal pain. He says that he's not really going to the bathroom because he's not eating, malodorous urine, dizziness, sleep disturbances. And then for his vitals, everything is pretty normal looking there. And 1 liter of oxygen. And then we have our physical exam, which is not too crazy. He's got some warm and dry skin, some skin flaking, says that he has dry mucous membranes, no edema, regular work of breathing, some crackles, and then otherwise it's not really engaging in conversation. And we can see his medication list there. Any questions about the information provided? Okay, and so this guy's admitted with a diagnosis of failure to thrive. So take about 3 minutes with your teams. So we have 2 teams here in the room, and then we'll do 1 whole team on Zoom between all of you there. And give me as many things on your differential as you can think of for round 1 about why this guy is coming in with failure to thrive. And just remember, be as specific as you can. So just saying malignancy, give me what type you're thinking about,
opioid use, I don't know if that would cause like a decreased appetite of it, just kind of somnolent medication. Yeah, now it's bleeding. Yeah.
And remember, the sky's the limit. We want as many diagnoses as possible when you're first starting off. Anybody gets the correct diagnosis, then you'll win a prize. If you did, nice one. Yeah.
Yeah. Yeah.
All right, so 3 minutes are up. Let's talk through. We have two groups here in the room, and then Zoomers have not typed anything into the chat yet, but we will get their responses. So let's come up with your differentials. So we'll just do team 1 and team 3 for in the room, and then Zoom will be its own. So what came up on your differential for this particular guy admitted for failure to thrive?
Should we just list all of ours?
Yeah, give me whatever you guys think is your top differential, and then you can talk through what else is in your mind and why you guys think that.
I don't know.
Soft field cancer, head and neck, squamous cell carcinoma, pulmonary, colon cancer, or did you say hypothyroid,
Depression, dementia, heart failure, pulmonary hypertension, like cardiac sarcoidosis. Sleep,
Okay, and then if you guys would pick one of those, what would be your leading suspicion?
Our least.
Your leading, your top.
Sorry.
Obstructive with eating. I think it'd be something that'd be obstructive with eating, maybe like esophageal.
Okay, so worried about some sort of malignancy, GI tract, primary concern.
Yeah.
Okay, and what I was hearing is that you guys are mostly worried about the fact that he was having some trouble swallowing and that he's lost weight, and that's what's leading you to think about a GI cancer as the primary diagnosis. Okay, all right, table 3, what's on your mind? What are you guys thinking about for this guy?
We had a lot of the same ones. We also had the GERD/strictures on there, but hyperthyroidism also. And then also maybe stage heart disease causing a fourth stage causing.
Okay, and then if you guys had to pick one as your top, what would you pick?
I think we would also pick like esophageal head and neck cancer.
Okay. And then Zoom, what about you guys? What's on your mind for this guy? Jordan is worried about a GI malignancy. Can any specific type? Are you also worried about esophageal, or is there something else on your mind, Jordan? Okay. All right. Sounds good. So everybody's worried about some sort of esophageal pathology for this particular guy's coming in with weight loss and trouble swallowing. So guys, hope that you wrote down whatever you needed from that first slide. We're going to slowly scan down to our next piece of information. Okay. So round 2 of information. He gets some labs on admission, which you can see there. White blood cell count of 14, anemia to 10.2. Platelets are 850 for his BMP. Only real noticeable thing, he's got a creatinine of 2.6, some LFTs. Again, they're written total protein, then albumin, total bilirubin, and then direct, if it was included, AST, ALT, alk phos. A PHQ-9 and a G8A7 were done. They were both negative. We have a chest x-ray, an EKG, and then a renal consult was called the first day he was admitted. And they said this is likely a pre-renal AKI or his new baseline since he's been bumping up and down. He could just have outpatient follow-up. So I will give you guys another 3 minutes to work through your updated differential. And what I explicitly want to hear is how does the information help you cross off certain things on your list and like what new stuff might be added based on the information that you have. I will also zoom in on the labs, the chest x-ray, and the EKG for about a minute at a time so you guys can make sure that you see everything. Sound good? No calcium. Okay. All right, so here we go. I'll zoom in first on your labs, just make sure that you guys can see all of those and think about them.
I don't know. Or like,
Okay, so now we'll zoom in on the chest x-ray. Okay, and then we're gonna push over to his EKG. I will zoom out again and you guys can look at everything one more time at the end. Okay, so I'm gonna zoom out and give you all the information again.
Oh. Yeah.
Okay, so let's maybe start with table 3 this time. And let's talk through what you make of these labs, what you make of these studies, and how that has changed your current differential for this patient coming in with failure to thrive. So,
I guess some of the things we first started talking about is that there's a large protein gap. So on our differential for that, we would the sarcoid or any other infectious. We were able to cross out thyroid TSH.
Perfect.
Will also break your cross out depression.
great.
Come to the chest X-ray, which again we kind of felt we had trouble looking at the esophagus, also trying to find the liquid circles on the heart as well.
Yeah.
But then I think we were still kind of considering surrounded as kind of our breathing.
Okay. And then I'm going to push you guys to be a little bit more specific. So we know that this guy has sarcoidosis, right? Like that is a known diagnosis for this gentleman. And so when you think that sarcoidosis is the cause of his failure to thrive, can you walk me through what you think must be happening with it to cause his current presentation?
I think maybe in this case, if it's becoming a bit more infiltrative, because of a bit more, back to what we were talking about earlier, this congestive heart failure could lead to some sort of overflow. But now I'm speaking of that.
Okay, great. Anything else to add from that group? Okay, group 1. How did your thoughts change after seeing labs, chest x-ray, EKG?
Covered it pretty well. Also noted that from the cytosis that all the way back up and there's no part of the chest.
And then did that thrombocytosis, leukocytosis push you to any differential or eliminate anything for you?
Sounds like still could be an infectious process somewhere, but we don't really have anything like pointing us in one direction in terms of where that would be.
Okay. All right, and then what's still your leading diagnosis for now?
All of that work. Yeah, all of it treated with the cardiac sarcoid, thinking like we're building that.
Okay.
Heart failure.
Okay, so we're worried about cardiac sarcoid or heart failure in these 2 groups. Folks on Zoom, anything else to add? And then let's zoom out and look over here. So the chest x-ray, he has a chronic sarcoid. How would you describe this particular pattern of infiltrate on his x-ray? Alveolar or interstitial? Perfect. And so you can see all of this stuff like out here in the periphery. It looks like fine markings all throughout his lung fields. So it'd be consistent with his sarcoid. This is a male, but we see lots of chest tissue in front. So that's why you're getting this overlap between his belly and then his breast tissue there. And then his heart is back here. His gastric bubble is just sort of in the way. of being able to see his heart border. But I promise you, he does have a heart there. Okay, so does this chest X-ray give us anything, new in terms of his workup? So we know he has sarcoid. Are you guys seeing anything like a big pneumonia?
No.
Are you seeing like a huge mass that's like pushing the trachea, causing deviation? Okay, nothing that we can see right here. And then how does his heart look in terms of its general size? I'll sort of like outline where it's laying for you. So maybe a little big. Okay. And then let's look at the EKG. Anybody want to talk me through what their thoughts were on this? We can zoom in.
It's regulated.
Mhm.
It has a P right in front of every urus complex except, so it's sinus, but P waves with some of it there, and I couldn't interpret that well. The QRS is narrow enough to not consider a heart block.
Perfect.
And then we have sort of early progression in V1 to V6. Because I think they need to be down first, and we want more down than this.
And then I liked how you commented on heart block. Why are you looking for that on an EKG, especially in someone with his history? Yeah, so he has sarcoid. If we're worried about cardiac sarcoid, then we should be looking for evidence of that. And so third-degree heart block could be manifested with complete heart block. Or sorry, sarcoid could be manifested with complete heart block. Yeah, perfect. So we don't see that on this EKG.
He does have LA left anterior.
He does, yep. So maybe this is the beginning of some sort of infiltrative disease in his electrical conduction pathway, or maybe that's something that's been there. Okay, questions on this part? Let's zoom out. Okay, so now we have hospital day 2. He is here. He has an acute change in his clinical status. He's now febrile to 101.5. Heart rate is in the 90s. Blood pressure is still around 90s over 60s. He's on room air, satting fine. In terms of his physical exam at this point, I'll let you guys look through. But otherwise, no major changes compared to his admission to now. Things for you to note, he's on room air now. He's on 1 liter when he came in. His right lung is clear. His left lung has diminished breath sounds. He's got some clubbing in his fingers that were noticed. Slight edema in his lower extremities. He has a condom cap on. No lesions, rashes. He still has this flat affect that he came in with. And then it's given you some additional labs that were drawn on this day. So white blood cell count is up to 15.8. His hemoglobin is 7.4. His platelets have come down. And then for his kidney function, it's down to 1.9. And then a full set of thyroid studies were obtained with the T3 and free T4, which you guys can see there. Since there's less information being given with this one, I will give you guys maybe about 2.5 minutes to talk through any updates to your differential. If you guys get finished before that, then we can just move on to the next one.
So just to clarify, I mean, the patient comes in with difficult to swallow, if they're distracted, that he can't swallow, right?
One more time, I just couldn't hear you.
He has difficulty swallowing, he has difficulty eating.
Mhm.
And so. Can he eat?
He can eat. Yeah,
He ate fine.
he was eating.
Okay, and no speech.
Not eating much, but he had a speech evaluation and his swallow was normal.
Okay.
So one that would be like now. Before.
Is it different for
Yeah, like dry swamp.
Yeah.
Because he was eating, but I guess he's eating in the hospital.
All right, so we'll flip and we'll start with this side of the room now. How does this new information impact your thinking about his workup?
I guess we're worried more acutely about infection with the white blood cell count and fever.
Okay. And then be specific. So what kind of infections are you worried about? What sorts of things are you going to investigate for him?
Maybe one side lung sounds to be like pass through, actually no, the right side is clear. But otherwise, like with the swelling, generally speaking, like aspiration, pneumonia, maybe like some sort of hospital-acquired pneumonias, like
Okay, what else?
See it for other like gastroenteritis, UTI.
All right. And so that might explain his change today in hospital day 2. But do you think any of this could impact the last 3 to 4 months of him not feeling well?
Not any of these particular specific things. No.
Okay.
This is we're reacting to this more like an acute infection that he acquired here as opposed to the patient.
Okay. And then what do you guys want to do for workup with him? So if he's your patient, what are you going to order? What are you going to look for?
We're gonna get another chest X-ray.
Okay, chest X-ray.
Yeah, UA, urine culture.
Okay, so infectious workup.
Right?
Okay. So wants to pursue an infectious workup.
Yeah.
Maybe like we talked about urine protein granulin or active for the like liver extraction.
Okay, and what are you worried about?
About?
So he's got edema.
Worried about nephrotic syndrome or purpose.
Worried about what's causing nephrotic syndrome, which is probably what the reason he came for us, was like all the protein, all the urine platelets, and the protein.
Yeah. Okay. Table 3.
The only other thing we were thinking about is you're confused about the hemoglobin drop. So we were also thinking look up and studies for VA Chapter.
Okay. So iron,
And any
LDH.
evidence of GI bleeding?
Hapto. No evidence of GI bleed. He got some fluid on his first day in the hospital. But no melena, no overt bleeding when he was there. Okay. All right. And then Sam, if you had to pick of these 3 studies that you gave me for somebody with an acute hemoglobin drop from 10s to 7s, which ones do you think are helpful and which ones do you think are not helpful?
I don't think I have studies.
Yeah. Okay, so I'm gonna explain his long-term anemia, but not gonna give us an answer for the acute drop. Great. Okay, and then, so you guys are thinking about your diagnostics. What sort of things are still on your differential for this guy in terms of his failure to thrive now, CIRSE type picture? Last round, you worry about cardiac, sarcoid. Okay, yeah, endocarditis. And what is your thought process there, Roxana? Yeah. So, you know, he's been sort of having this subacute smoldering picture of just not feeling well, losing weight, feeling weak. You know, does he have some sort of subacute bacterial infection that is causing this? Great thoughts. Anything else to add, anybody?
I think a smear would be really helpful on this person, like he came in with platelets of 800,000 and now they're 400,000, the platelets normal looking. Just as I see it, so I think figuring out what are all these issues in the blood look like.
Great.
And
Okay.
if he had like nephrotic syndrome or some sort of like marrow infiltration, then like suppressing the immune system and then he is.
Okay, perfect. Great thinking. Okay. So round 4 of our information. It's a lot of lab work. So I will give you all of that. Let me move these up. Okay, and so since this is more information and for you guys to refine and think about your differentials, I'll give you guys about 5 minutes to walk through this. And if we end early, then we'll just move on to the differentials and get to our last round of information. I can make this bigger for you too.
But then she started.
Yeah, we really just need like this one. We either just need like a swab or just figure out. With blood in there. Oh, wow, yeah. Especially like the one we sent to us.
Yeah. I think it gets.
But it's great.
I misremember that. What was all this like? That is historical diagnosis. I thought it was
He
vasculitis.
has-
Oh, you did that.
Some sort of.
For some reason, I had to pull myself this vasculitis.
But
Oh,
he did
okay.
have that.
Yeah, that's because.
I think probably less. schema for like. non-diarrhea.
Okay, conversation starting to wind down. You guys want to wrap up any final thoughts? Seeing hands thrown in the air.
We thought maybe a GI method, like blood and protein, or like that could be a bit suited to sarcoid. Maybe like a vasculitis or cryo,
Okay, so GN,
but we think less likely infectious.
vasculitis,
Do we
cryo,
know what kind of diet he was on, like a liquid diet or a solid, regular diet?
just regular food.
Regular.
Yeah.
Okay.
Okay, so tell me more about what's pushing your hand to move away from infection towards maybe like vasculitis, glomerulonephritis, cryo.
Because the only physical was in the only thing where we found was that was changing his respiratory trend and the chest X-ray came back, was just it increased sarcoid and ways blood cultures.
Okay, so yeah, infectious wise, it looks like his blood's not growing anything, his urine's not growing anything. Thought about a cap or a HAP, but he's now in room air. There's no pneumonia that's seen in his CT chest, so perfect. Love how you guys are thinking about that. And then I like that you guys are now opening up your differential to think about other things. So I think I heard Richie you talking about like renal lung involvement. Is that a vasculitis? So love that you're opening up your differential. Table 3, thoughts? Did anything help you cross stuff off? Did you expand your differential with this?
I guess we mostly got like a lot of the abnormal findings we can explain by diagnosis of urine caries. So I don't know how helpful it was to say like, okay, yes, an elevated ESR CRP, so maybe whatever autoimmune processes he's already had, or inflammatory processes he's already had could be flaring, but I don't see evidence of new disease necessarily.
Okay, and so walk me through what a flare of each of his autoimmune diagnoses would look like.
Totally. I suppose rather than flare, maybe any progression of disease, like
Okay.
sarcoid looks like it is continuing to progression, like use pattern, and then is like RBCs and his kidneys and protein there could be consistent with his previous glomerulonephritis. So I read that much.
Okay. All right, anything else to add by anybody in the room?
We still thought like maybe an echo would be helpful, just to see like with the worsening progression in the sarcoidosis, you have like pulmonary hypertension.
Okay.
Like, and that would also allow us to see if there was like an infiltrative process.
Really pushing for the echo?
I don't know. I'm just saying like, we've done everything else. Unless you want to do a kidney biopsy, but.
I'm gonna disappoint you because there is no echo that was obtained. So here's our last round of information. And again, this is all like the real labs that the team ordered and studies that they ordered. And so I will give you guys a chance to look through this, and then we'll keep this part shorter. I'll give you about 2.5 minutes or 2 minutes to think about this, and then we will come together for our final reveal. And so I want each of you guys to put down one diagnosis that you think encompasses this patient's presentation.
Oh, that's higher level.
MAC team to PVN, patient visitor north, level 6 near the elevators. MAC team to PVN, patient visitor north, level 6 near the elevator.
Gonna love that. Right, well, I was overpercent GPA has upper and lower respiratory tract.
But then that's
Oh, yeah, that's.
58, that's like the yeah, like the, like,
Yeah, I don't know what stands for that.
oh, microscopic volume. Something like that.
That's the multiple choice of click it. Churches.
But I don't know. But I think microscopic volume
Yeah, that's.
20. And normal circumstances, but greater than 200 is like diagnosed. Right, so it's like, well, you can remember it. It's rough. So LH is cool. I can't. So.
Okay, let's come back together. Get your final diagnosis written down. And then we will chat for the last 10 minutes about what's going on. Whoever wants to go first, go ahead and shout it out.
MPO, micro polyangiitis.
MPA,
MPA.
micropolyangiitis, microscopic polyangiitis. Okay. Team 3.
That's fine. So I don't know what else is.
Other what? Okay, so a Pianka something. So maybe Short Strauss. Okay. All right, you guys ready for the final reveal? Okay, so our final diagnosis for this guy was a systemic MPO positive Pianka vasculitis. Love that you guys both got to the rheumatology area by the end of your diagnoses, and we'll walk through each of the pieces of information. So for him, he did have a history of a post-immune rapidly progressive glomerulonephritis. That could be considered a renal limited vasculitis. So when he was diagnosed, it was just his kidney that was involved. The fact now that he started having systemic features, so things like fevers, weight loss, poor appetite, weakness. He also had some adenopathy that developed later on. That all plays into a transformation of his ANCA vasculitis from being a renal limited vasculitis to a systemic process. And so when he was admitted, lots of people were like, oh, well, he's just depressed, he's not eating. That's why this is a problem. He had sarcoid. Did he have progression of that? He really had no respiratory symptoms in terms of like rhinosinusitis, hemoptysis, to argue for worsening of his sarcoidosis from a symptom perspective, nor did he have any pulmonary involvement for like a vasculitic process. So that's how ultimately, after sending off the ANCA titers, we came to the conclusion that with a positive ANCA titer that is now higher than his previous and elevated markers of inflammation. So if we go back to look at his ESR and CRP, those are astronomical. If you ever see a patient with an ESR over 80, you need to rule out A, a malignancy, and B, a rheumatologic diagnosis. That is not normal. No person is walking around with an ESR of 80 and feeling fine. Same thing for a CRP being that high. You have to rule out a malignancy, some sort of infection, or like a rheumatologic process. Okay. For him, he ended up getting a prednisone burst. He felt immensely better once he was given some prednisone, and then he was on rituximab for maintenance therapy. They had wanted to start him off on Cellcept given his renal involvement, but he didn't want a bunch of appointments and wanted something easier. So rituximab is something he could get once every 6 months and have some benefit from. Any questions on him or his clinical course or how we make that distinction between a renal limited versus a systemic vasculitis? So the key feature there is that he just had all of the like general complaints, pan positive ROS. That means that it had progressed outside of his kidney. Okay. Just a few points on naming conventions. So sometimes in rheumatology notes, you'll see things like P-ANCA, C-ANCA. That has to do with the immunofluorescent staining pattern. So perinuclear versus cytoplasmic. And then if you see MPO or PR3, that has to do with what antibody is being targeted. So either myeloperoxidase or proteinase 3. And so usually MPO goes with P-ANCA, usually PR3 goes with C-ANCA, but there can be crossover. That's just for you to better understand if rheumatology is leaving notes or nephrology is leaving notes, what these things mean. And then lastly, so a short review of small vessel vasculitides. So I heard you guys talking about a lot of these, which is great. So we have granulomatosis with polyangiitis. The classic story there is that they'll have some sort of sinus involvement, some sort of respiratory symptom. You can see on the UA that they have some renal involvement. A chest x-ray will be abnormal, and to diagnose, you can get some sort of tracheal or upper airway biopsy. Microscopic polyangiitis. So they usually have respiratory symptoms that involve some sort of hemoptysis or hemorrhage. They're the classic like pulmonary renal syndrome folks. Again, their UA will be abnormal, their creatinine will be abnormal, and you can get either a kidney or a lung biopsy to confirm that diagnosis. Eosinophilic granulomatosis and polyangiitis. These people usually have more lung involvement. So they have rhinitis, they have asthma, they have a mononeuritis. They usually have a positive P-ANCA. Their UA, again, can be abnormal, as well as their chest x-ray. And then these folks are usually diagnosed with a respiratory tract biopsy. And then lastly, a renal limited vasculitis, which this guy had. His RPGN was a renal limited vasculitis when it started. You'll have your ANCAs, your UA, your creatinine, and if you get a kidney biopsy, you can find it there. Questions on this? Okay, and then just a word on failure to thrive. So it's a personal pet peeve when I see adults admitted to the hospital with failure to thrive. It is not an adult diagnosis, and I encourage you all to be a little bit more curious with your differentials. So if somebody comes in and they're losing weight and they have a stage 4 cancer, you can call it cancer-associated cachexia. If somebody has terrible COPD and they're coming in with dyspnea and weight loss, you can call it end stage, gold stage 4 COPD or whatever they have. And similarly, somebody comes in, they have terrible dementia, they're really not doing well. Do they have severe protein calorie malnutrition due to their dementia? This, I think, helps us stay honest to like why the patient's coming in. It helps families better understand the progressive nature of their chronic conditions. And it prevents us from just sort of like anchoring on this failure to thrive diagnosis and then just thinking in our minds, oh, they just need placement. Oh, they just need to go to hospice, because there have been plenty of patients like this guy where everybody just had failure to thrive, and he had an active vasculitis that could be treated, and he felt better after this was done. So keeping your differential broad. And if you guys haven't seen, there's a pretty good schematic for a weight loss workup. And so if you have someone come in and you take your targeted history and physical, they have no evidence of a malignancy, no history of an absorption issue, or no evidence of infection. And you're like, I still don't know what's causing their weight loss. I would encourage you to think about sending off some of these labs that are listed. So CBCs can help you with hematologic malignancies or hematologic issues. Obviously, your BNP, calcium, LFTs can talk about liver, kidney issues. The UA, so his UA was not normal. The fact that he had blood and protein with RBCs and YBCs, that is the active sediment that we talk about in rheumatology. And so paying attention to that and seeing if those things are new can help diagnose a vasculitis or other renal issue. And then ESR, CRP, HIV and Hep C screening, and then a chest x-ray to look for any sort of infiltrative process. And then obviously they just need their up-to-date cancer screening. So just remember, everybody should have a good skin exam. Everybody needs colon cancer screening, breast or prostate if needed. And then if they meet criteria for lung cancer screening, think about that too. Questions on any of this? Okay, great job, guys, on your workup.